Welcome to NCLEX RN Review, produced by Nursing Tutorial and Consulting Services. This session is on cancer and blood disorders. I'm Judith Miller, and I'm going to be your guide during this session. When we start to talk about cancer, to define cancer is a little bit difficult. I just usually define it as cell division gone crazy or cell division gone wild. Normal cells know when to stop dividing. Cancer cells don't. And this is really what differentiates cancer cells from normal cells. When we know that cancer is not just one disease, it's many diseases. And so there are a lot of things that contribute to the cause of cancer. If we look at environmental factors, radiation, while we use it to treat cancer, it can also cause cancer. Chemicals and drugs are known to cause cancers. Would you want to live next to a plant that was spewing chemicals into the air or water? Of course not. Smoking is an environmental factor that can cause cancer. And if I were to ask you what kinds of cancer does smoking cause, you would probably tell me lung cancer and maybe throat cancer or mouth cancer. But it's statistically linked to many cancers. It's linked to bladder cancer. Most of the studies will suggest that smokers are at increased risk for virtually every kind of cancer. So if you would like to get cancer, you could increase your chances of getting cancer dramatically by smoking. Other things in the environment that can contribute to cancer is even good old sunshine, because too much ultraviolet rays can contribute to the development of skin cancer. Now, genetics is certainly a factor in many cancers. So some cancers that would be related to genetics, that have a genetic link. Most of you would think immediately of breast cancer, and that's certainly true. Some types of breast cancer are genetically linked. Other cancers, though, colon cancer, ovarian cancer, and colon and ovarian cancer are linked to each other. There is a type of leukemia that we see in older men that is hereditary. So there is certainly a hereditary predisposition to some cancers that we've readily identified, and probably to other cancers. We didn't used to think that viruses and bacteria cause cancer. Now we know that some of them do. For instance, cancer of the cervix is caused by some strains of human papillomavirus, which is what causes genital warts. So genital warts caused by human papillomavirus can cause cancer of the cervix and cancer of the penis. So if you really wanted to be technically accurate, you could describe those two cancers as sexually transmitted diseases. We didn't used to think bacteria caused cancer. Now we know it can. For instance, Helicobacter pylori. This is the bacteria that causes stomach ulcers. We now know that stomach ulcers, H. pylori infection, that H. pylori infection is related to stomach cancer. So treat your ulcer, prevent your cancer. Now, immune system failure. Normally, our immune system protects us against attacks by many things. We're constantly being surrounded by not only bacteria and viruses, but carcinogens. And our immune system acts like an invisible shield around us that protects us from it. When the immune system is compromised, you're at greater risk for cancers. Now, sometimes we can have this compromised by diseases such as HIV and AIDS. And what kills AIDS patients is really the infections and cancers they get because of their compromised immune systems. You may have also seen patients who were treated successfully for one cancer, and they had radiation and chemotherapy, which had immunosuppression as a side effect. And you find that they develop another cancer totally unrelated to the first because of their compromised immune system. So these are some of the things that can relate to the development of cancer. Now, I'm including in our discussion today this element on cancer's warning signs. I don't think you need to memorize the list, but I think you should be relatively familiar with it. This has been put out for many years by the American Cancer Society. So any of the items on this list could suggest possible cancer. None of them prove you have cancer. Now notice that the first letters of each item on the list spell out the word caution if you line them up. You don't have to memorize that. They're never going to ask you what's the T in caution stand for. But anybody that has changes in bowel or bladder habits certainly should see their physician. It might be something relatively minor, but it could be a sign of cancer. A sore that doesn't heal, unusual bleeding or discharge anywhere, whether it be vaginal, breast, any part of the body. Thickening or lumps in the breast, we might add testicles elsewhere. Those could be indications of cancer. They could also be benign lesions. Indigestion or difficulty in swallowing could be benign, could be a sign of cancer. An obvious change in a wart or mole. For instance, most warts and moles are relatively round in shape, and they have fairly regular borders, and usually a fairly solid or similar color throughout the lesion. If it begins to get irregular borders and multiple colors, that's a real warning sign that you might be dealing with a melanoma, a skin cancer. This is something that can't afford to be ignored. Nagging cough or hoarseness might simply be a cold, but if it continues, it could certainly indicate lung cancer. It's very difficult to tell when the smoker's cough becomes the cancer cough. But these are all things that should be investigated because they could possibly be cancer. I could see a question on the exam that might say something like, the nurse is teaching people in the community about warning signs of cancer. Which comment by one of the persons would indicate a need for a referral to the physician? And you'd pick up something that dealt with one of these items. We also need to think a little bit about early detection of cancer. And there are some items that we know they've asked about on NCLEX. One is self-testicular exam. So they've asked about how frequently it should be done. And the answer to that question is monthly. Now, men don't have a menstrual period to tie it to the way women do for self-breast exams. So we simply recommend the same date every month, the 1st of the month, the 15th of the month, payday, something that the person is going to be able to remember. We recommend that this be done during bathing, because if a person puts cold hands onto the scrotal area, there's a reflex that pulls it back up close to the body. So it's nice to do it during bathing. And we ask the man to use his thumb and his first 2 fingers and gently palpate each testicle and also up the spermatic cord. You should be feeling for lumps, bumps, the same way that you would do for a self-breast exam. We ask him to do that to each testicle. We also ask him to look into the mirror. And the testicles should be roughly the same size and shape. Now, one usually hangs lower than the other. The left is usually frequently lower than the right. Other than that, though, they ought to be relatively symmetrical. If they aren't, they need to see their physician. There are benign problems. Not all problems with the testicles are cancer. But testicular cancer is one of those cancers that, when found early, is very, very curable. We have good cure rates with testicular cancer. Suppose that you were going to teach people how to do self-testicular exam. So where would you target your teaching? Would you do your teaching in a long-term care facility, or would you do it on a college campus? Now, I hope you're answering college campus, because testicular cancer is a young man's disease. The peak age for testicular cancer is in the 20s and very early 30s. So it's a young man's disease, but it's highly curable when detected early. Another type of self-exam that is frequently asked about on NCLEX is the self-breast exam. This also is done monthly, but it should be done about a week after the onset of menses, so just after the end of the menstrual period. At that point in time, the breasts are usually the least tender. And we ask the woman to palpate the breast in both a standing and lying condition, making sure that she gets all aspects of the breast, from up into the axillary area all the way to midline. And it can be done in circles, it can be done up and down, it can be done in wedges, as long as the entire area is palpated. We also ask this woman to look in a mirror. And again, looking for symmetry, looking for any dimpling, which is puckering up, or any bulging out. Any of these things should be reported to the physician. We also recommend that women have a health professional do a breast exam on an annual basis as well, as part of their annual physical exam. Now, a couple other types of early detection of cancer I just want to mention for us. A stool for occult blood and a colonoscopy. What kinds of cancer is this trying to pick up? That's right, colon cancer. So which would pick it up earlier? The stool for occult blood or the colonoscopy? The colonoscopy. Because with a colonoscopy, you're actually looking at the bowel and looking at the tissue. Whereas with a stool for occult blood, you have to have a lesion big enough to bleed before you can pick that up. Now, it's certainly much easier to do a stool for occult blood because the preparation and procedure for the colonoscopy is much more complicated, but it does pick it up at an earlier basis. We start doing colonoscopies in close to midlife. If there's a history of colon cancer in the family, it ought to be done earlier. Now, the good thing about colonoscopies is it's going to take 5 to 7 years for a beginning problem in the colon to get big enough to really begin to spread and cause difficulties. So if you do a colonoscopy and it's clear and there's no problem, they're going to call the patient back 5 years, 7 years from now for another colonoscopy. If there are premalignant polyps or other things, they may call them back more frequently. But it's not something you have to have done on an annual basis. And that's good because the preparation is difficult for that. All right, now I want us to take a look at cancer chemotherapy. I sincerely hope that everything that I am going to discuss today about cancer chemo will be found to be outmoded and old-fashioned very soon. I think we're really on the cusp of new methods of treatment of cancer, and these are going to happen soon, I believe. But I do want us to take a look at some of the traditional methods of treating cancer, because these drugs and these approaches are still widely used. Now, all of these categories that are on the picture for you, these 4 categories of drugs, are drugs that have been around for a long time. And what all of these drugs do, one way or another, is interfere with cell division. If we said that cancer was cell division gone crazy, the drug's purpose is to stop cell division. Now, they do it by different ways. The antimetabolites, for instance, these are your drugs like 6-mercaptopurine and methotrexate and 5-fluorouracil. These drugs pretend to be something that the cell needs to multiply. So, for instance, if you have a folic acid antagonist, it says, hey, pick me up, I'm folic acid. And when the cell picks it up, it goes, I'm not the real thing, and cell division stops. So it pretends to be something the cell needs, and then when the cell picks it up, it says, I'm not what you need, and cell division stops. Now, the alkylating agents work a little bit different. If you remember the double helix on the DNA strand, the alkylating agent cross-links that and messes those up. The vincas, sometimes also called plant alkaloids, are substances that come from plants. The vinca is related, it's a ground cover. and it's related to a common ground cover. You can always pick up one of these because the word vine, V-I-N, is in it, like vincristin, oncovin, vinblastine. And these work a little different. They work on something called the spindle apparatus, so they work on a little different point, but they interfere with cell division. The anti-tumor antibiotics all sound like antibiotics because they've got this icin in the name, adriamycin kind of thing. And they not only would kill organisms, but they actually kill the host cell in the process. So they're not good as regular antibiotics, but they do kill cancer cells. Now, all of these types of drugs interfere with cell division in general. They are not specific for a particular cancer cell. Hopefully, we're going to be getting a whole new array of drugs with the monoclonal antibodies and some of those that can actually target specific cancer cells. When that day comes, we'll be really on a new way of treating cancer. But in the meantime, a lot of these drugs are being used. So I sometimes call these drugs that are not too smart. I sometimes call them a little bit stupid because they don't know the difference between cancer cells and normal cells. They interfere with cell division in general. So this works, but it's almost like using a shotgun to kill a mosquito because you're doing more damage not just to the cancer cells. So these chemotherapeutic drugs interfere with cell division. If we look at side effects of the drugs, we're looking at rapidly dividing cells because cells that are rapidly dividing are going to be the ones most susceptible to these drugs. And the most dose limiting of these side effects is bone marrow suppression. Your bone marrow is constantly making red cells, white cells, and platelets. And if you give these drugs, it interferes with that. So people get anemic because they're not making enough red cells. They are immunocompromised because they're not making enough white cells, and they bleed easily because they're not making enough platelets. That is the most dose limiting of the side effects of cancer chemo drugs. Another one, though, is alopecia. Hair loss. Hair is constantly growing. And patients who get these cancer chemo drugs frequently lose their hair. There are a couple nursing care things they might ask about hair loss. If we think about hair loss on the head, which is a common place to think about it, if the person has extremely long hair, we usually suggest that they cut their hair before they start the chemo. Because when that hair begins to fall out in handfuls, it's a little easier if the hair is 8 inches long than if it's 18 inches long. So we often recommend that they cut their hair. We also recommend, particularly for the ladies, that they might want to be fitted for a wig or invest in some scarves because bald heads in women are just not as socially acceptable as they are for men. The alopecia, or the hair loss, is not just on the head. You note that these patients also get shiny arms and legs. And I have had patients tell me that the hair loss that bothered them the most was pubic hair loss. Now, you can't walk down the street and say pubic hair, no pubic hair. I mean, you just simply don't know that about people. But when they get up in the morning and they see themselves in the mirror and they look like they're 9 years old, this is often a serious emotional impact, and one that you as a nurse should keep in mind as patients are going through this cancer chemo experience. Now, another area of side effects is the GI tract. We get side effects here for two reasons. One, the lining of your GI tract from your mouth all the way down to the other end of the GI tract, that lining is replaced every 2 to 3 days. So it's constantly being replaced. So that's fairly rapidly dividing cells. That explains why we get stomatitis with cancer chemotherapy, the terrible mouth sores that these patients get. By the way, if a patient had stomatitis, for a mouthwash, would it be better to use a Listerine-like mouthwash or viscous lidocaine? Viscous lidocaine is much superior because that has a local anesthetic effect. A mouthwash like Listerine is a high concentration of alcohol, which would be exceedingly painful in the open sores that they often get in their mouth. There's another problem with the GI tract, and that's a really severe nausea and vomiting. And some of this may be due to the replacement of the lining of the GI tract, but there's another cause for that, and that's the direct effect on the vomiting center in the brain. Some of the drugs stimulate the vomiting center in the brain, and so you'll note that within a half an hour to an hour of the time they get the drug, the patient is starting with some serious vomiting. This is usually due to the stimulation of the vomiting center. And these patients are really going to require antiemetics before they receive their cancer chemo drugs. As the cancer cells are being destroyed, we oftentimes will see an elevated uric acid level. And of course, that can lead to gout and kidney stones. So many of these patients that are receiving cancer chemotherapy will also be on a drug called allopurinol or Xyloprim, to help prevent the gout and kidney stones that can be associated with high uric acid levels. And just remember, whenever you give allopurinol, push fluid, so we'll flush all those uric acid crystals just right out of the system. Now there's a specific drug that I wanted to pull out because I'm pretty sure there's been a question about this from time to time on the exam. And I'm going to pull out Cytoxan. And one of the major side effects of Cytoxan is hemorrhagic cystitis. Now, if you look at the picture, you note that I set this up with a memory tool in mind. There are certainly other words that start with CY, but not too many words in the English language that start with CY. And I thought that might be a memory tool, that Cytoxan can cause cystitis. Now, the mechanism of this is that the metabolites, the breakdown products of Cytoxan, are still toxic. And one of the things that they can do is to cause this damage to the bladder because those breakdown products are excreted from the body through the urinary tract and through the urine. So to prevent damage to the bladder, we tend to push fluids because that dilutes those breakdown products, those metabolites. And we also have the patient empty their bladder frequently because that limits the time that it's exposed to those metabolites or breakdown products. So pushing fluids and emptying the bladder frequently or frequent voiding are things that we will do for patients receiving chemotherapy, particularly the drugs like Cytoxan. There are some others that could also cause damage to the bladder. Let's look at a question. A client who is receiving chemotherapy for cancer complains of nausea, but is not vomiting. Which action by the nurse is most appropriate? Number 1, recommend the client eat his favorite foods. 2, suggest the client eat bland foods only. 3, offer sips of ginger ale to the client. Or 4, encourage the client not to eat or drink anything. And the correct answer is number 3. We want those clear liquids for the patient. One of the worst things you could do would be to suggest that he eat his favorite foods. Because if he eats his favorite foods and he associates those with nausea and vomiting, then you've made him not like his favorite food anymore. So that's kind of a cruel thing to do to patients who are at risk of nausea and vomiting. Now, if we look back at this next picture, you notice that to the picture of the kinds of drugs, I've added another box with a couple more types of drugs. And these are the corticosteroids, your prednisone, cortisone family of drugs. Dexamethasone is another one of those commonly used. These are often used as adjuncts to cancer chemotherapy. They aren't usually, occasionally, but they aren't usually used as the only drug, but they're often used as adjuncts to other cancer chemotherapeutic agents. And they would have all the side effects of steroids. We'll talk about those in more detail in the endocrine session. The other drug that I've added to this group is hormonal agents. And I want to talk about tamoxifen, for instance. Tamoxifen is a drug that blocks the part of estrogen that stimulates the growth of estrogen-dependent breast cancer. So for instance, when a woman has had breast cancer and she's had surgery, as she often does, and followed by chemo or radiation, after the completion of that, this woman is likely to be placed on about 5 years of tamoxifen therapy. And this significantly reduces the chance of spread of the cancer and spread to the other breast and metastasis of the cancer. So that's one use of hormonal agents. The side effects from hormonal agents are more hormonal. They're not the complete bone marrow depression piece. A major side effect of tamoxifen is the possibility for clots. So these patients need to be alert to the fact that they could get a DVT, a deep vein thrombophlebitis. Now, we also give drugs that are estrogen-based to male patients, for instance, who have prostate cancer and male hormone-dependent cancers. And again, the side effects are more hormonally related. Sometimes the men receiving these drugs look like they're going through menopause because we're altering their normal hormone secretion. But those side effects are temporary in nature. We want to take a look at radiation. And we're going to look at both external and internal radiation. So we'll start by talking about external radiation. Radiation can interfere with cell division and kill cancer cells. That's the whole purpose of using radiation. Typically, a person may have radiation prescribed Monday through Friday for as long as 4 to 6 weeks, and sometimes we do a second round, so it's possible that they could be getting weekday radiation for as long as 2 or 3 months. Now, there's a few things I've asked about external radiation. One, the purple marks. Now, the radiologist is going to outline the tumor by using purple marks, either an indelible type pen or something like a tattoo gun, where they actually outline the location of the tumor. This is so that the radiation can be zeroed in. They'll cone in those rays so that they go right at the tumor site. Now, every once in a while, patients or their relatives decide that that's very unseemly, that doesn't look very nice on their loved one, and they try to scrub it off. So if you see somebody trying to scrub off the purple marks, the correct nursing action is stop them. If they did succeed, first off, they damage the skin, and secondly, they have to go right back on because it's the radiologist's roadmap. It tells them where to beam the radiation. A couple other things about patients getting external radiation. We use either just water for bathing or very mild soap and water. You don't want to use harsh soaps, perfumey soaps, because these folks have skin damage. It's like they've got a sunburn as they get the radiation. Another aspect, no powders for this patient. Money powders contain zinc. Zinc is a heavy metal. If you want to block radiation, you use a lead apron, a heavy metal. So if their body was covered with a layer of zinc, the radiation is not getting exactly where it's supposed to be. So no powders. We also don't use deodorants and antiperspirants because these contain aluminum, another heavy metal. Now, as a sidebar, this is the reason that you tell patients going for mammograms, no powders, no deodorants, because it blocks the radiation and makes it a less efficient mammogram. We want to be very careful and give good skin care to these patients. Now, if you take a look at the items on the screen, it says, no crowds. Why would we tell a patient not to be out in crowds? That's right, they're immunocompromised. Now, all the side effects that we talked about with cancer chemotherapy, we get them with radiation as well because it's interfering with cell division. So they get immunocompromised. They can get nausea and vomiting sometimes from radiation. They go to their first radiation treatment, they go in, it gets beamed at them, turned off, they leave, they say, no problem, this is easy. After a couple weeks of radiation, they're dragging, they're anemic, they have no energy. because of the decrease in the red cells in the bone marrow depression. I have a question for us. A woman is being treated for cancer of the cervix with internal radiation. The day after the rods are inserted, she calls the nurse and says, quote, "There is something between my legs. It fell out of me." The nurse determines that one of the radiation rods is out of place. What is the most appropriate initial action for the nurse? Number 1, call the radiation safety officer. Number 2, put on rubber gloves and put the radiation rod in the bathroom until help arrives. Number 3, place the radium needle in a lead-lined container using long forceps. Or number 4, calmly insert the rod in the vagina. Now the correct answer is indeed number 3. It's safety first. So take that radium needle using your long handle forceps, pick it up, and put it into the lead-lined container. After that, you can call the radiation safety officer. But the question asked us what was the most appropriate initial action. Now, they could also turn that question around and say, what should always be in the room of someone that is receiving internal radiation? And the answer would be a lead-lined container with long-handled forceps. Now, I want to talk just a little bit about internal radiation. For instance, let's think about a woman like the one that was in this question that has cancer of the cervix and will be having the rods placed into the vagina and pointing at the cancer in the cervix. I want to talk about preparation of this patient for that. So before the rods are inserted, this patient is going to have an indwelling urinary catheter, a Foley catheter inserted. Now think about it. Anterior, in front of the vagina, is the bladder. If that bladder is full of urine and distends, gets larger, it gets closer to the vagina and closer to the source of radiation, so it's much more apt to get damage from the radiation. So they'll have an indwelling urinary catheter. Now, posterior to the vagina is the rectum. If that was full and became distended, it gets closer to the vagina, increases the risk of things like rectovaginal fistulas developing. So the day before the rods are inserted, the patient will have a bowel prep, usually a laxative prep. And then they'll be on a clear liquid diet during the time the rods are in place. This patient that has the rods in place will be, so they have an indwelling catheter, they're on a clear liquid diet, they're in bed. We raise the head of the bed very little, flat or just the slightest bit of elevation, because we don't want them sitting up. That would increase the likelihood of dislodgement of the rods. Even though they're packed in there, we don't want to do anything that could make them dislodged. So you hope this patient comes to the hospital environment with plenty of books to read, her telephone list, and that the telephone at her bedside works so she can communicate with the outside world, and the remote control on the television works, because this patient is not going to have visitors and is not going anywhere. Now, the rods are not going to be in place that long. 1 to 3 days is probably about what we're looking at for that. But be sure to prepare the patient for that. If you want to reduce radiation exposure, you control time, distance, and shielding. You remember that radiation is cumulative, so you limit your time with the patient. You note that distance is important. If one nurse was standing 1 foot away from the patient and another nurse was standing 5 feet away from the patient, the nurse that's standing 5 feet away gets 1/25 the radiation of the nurse that is standing 1 foot away from that patient. So keep your distance. Shielding is important. Of course, you would never ever touch the radiation directly. And remember, rubber gloves give you no protection. They've got to be lead-lined gloves that would give you a protection. All right, so let me ask you a question. You have 2 patients that are getting internal radiation for cancer of the cervix. Can you put them both in the same room? No. Think how hot that room would be and how much damage they would be doing to each other. So if you want to get a private room, Guaranteed, internal radiation would do it for you because you don't want to expose others to that source of radiation. Now let's say that the patient getting internal radiation is to be in a 2-bed room. Of course, they're going to be the only patient in that room. Would you put them in the bed closest to the hallway so you could see them easier, or closest to the outside wall? Closest to the outside wall is the answer because you want to increase the distance for people walking up and down the hallway. If you increase the distance, you reduce the exposure. Now, as a nurse, you will wear your shield, your badge, that tells how much radiation you've been exposed to. Put it at waist level. That's better than chest level because the most sensitive part of your body to radiation are your gonads, your ovaries, or testicles. So keep it at closer to the waist level. That tells you how much radiation is in the most vulnerable areas of your body. Are there any nurses that should not be assigned to these patients with internal radiation? Yes, nurses who are pregnant, want to get pregnant, trying to get pregnant, think they might be pregnant. These nurses should not be assigned to these patients. Now, I want us to take a look at some types of precautions. And the first we're going to look at are bleeding precautions. We said that patients with chemo and also radiation tend to get bone marrow depression, decrease in platelets, and they bleed easily. So when patients have a very low platelet count, they may be placed on bleeding precautions. We're talking about this now in relationship to cancer. But remember, these same bleeding precautions will apply to blood disorders where you have a decrease in platelets. So the soft toothbrush makes sense. They might also ask a question about dental floss. And the answer is no, we don't encourage dental floss when a patient's on bleeding precautions because that could cause bleeding. Electric razors are much better than safety razors because there's much less chance of bleeding. Most of these patients will probably have a central line, and that minimizes the number of times the patient needs to be punctured. Now, the problem with constipation, you say, why must the patient avoid constipation? Because straining at stool could cause bleeding. And obviously, you would not give them aspirin or NSAIDs because these are anticoagulant drugs. Now, let's do a question here. An adult who has leukemia is admitted to the hospital. Which room assignment is most appropriate? Number 1, with a client who has cellulitis of the foot. Number 2, with a client who had surgery 2 days ago. Number 3, with a client who has pneumonia. Or number 4, with a client who has angina. The answer is number 4, with the client who has angina. Now you know that leukemia patients are immunocompromised, and those other 3 patients were all either had infections or the surgical patient was at risk for an infection. Sometimes they give you room assignment questions on the test. Now, we want to address neutropenic precautions or protective precautions, sometimes called reverse isolation. This frequently is instituted when you've got a white count below about 2,000. Now, it would seem strange, no fresh flowers, fruit, vegetables, but organisms can grow on these things, and you don't want to introduce them into the environment. Even cut flowers, if you've got flowers in a vase of water, the hospital has germs, and just think of what organisms could grow in that vase of water. For healthy people, that's not a problem. For immunocompromised people, it can be a serious issue. No rectal temperature suppositories or enemas. This isn't because of bleeding per se, but normally if there was any scratch or break in the mucosa, your white cells come and gobble up any organisms and prevent any infection. But if you don't have enough white cells and you've got a break in the rectal mucosa, then the patient could easily end up with a systemic E. coli infection. The same thing with urinary catheters. We don't want any break or source of introduction of infection. Now, if we look over on the do side, do use a soft toothbrush. Again, that is not so much to prevent bleeding, but if there's any break in the oral mucosa, the natural organisms in the mouth are not going to be fought off by your white cells because you don't have any white cells. So that's why we would use a soft toothbrush even with neutropenic precautions. Now, as we talked about with the bleeding precautions, neutropenic precautions are frequently used for patients receiving chemo or possibly even radiation therapy, but they're also used for some of the other blood disorders. So we'll make a referral back to this as we talk about